There is no such thing as guesses. All right, we talked a little bit about the vital capacity last time in that it's the basically the maximum amount of air you can take in followed by the maximum of the air you can exhale. If we do it in a relaxed, I don't say relaxed, but a slow maneuver, that's called the SVC. What we more commonly do, though, is a forced vital capacity. In normal lungs, those two values should be the same, but we'll find that patients who have obstructive lung disease, they actually have a different value, a much lower value than you would see with a forced vital capacity with a normal patient. And graphically, this is what it would end up looking like. I have my tidal volume starting off here. Get my pen. My tidal volume. Take a deep breath in, deep. Now blow it out, push, squeeze. Now, if I didn't make mention of this last time, one of the things that a pulmonary function technician gets to do is yell and scream at the patient because you want a maximal effort. And literally, you're screaming at them to get that done. Has anybody ever had a PFT done?
I've heard it done before. And they do that.
Yeah. Oh, you got to. You just... No, you want the best possible effort you can get in the process, okay? But that value that you end up seeing from the point of the start until the point of the end is the vital capacity. What would you say the vital capacity is numerically, looking at this graph?
8 seconds.
On that duration, not time, volume. No, it's not 6, guys, because where does it start? Oh, it starts at about 2.5, goes to about 6, so it's about 3.5. That's a rat bastard kind of a question. You need to make sure what you're looking at, starting point. Normally when I do them, I begin them, so it's down here.
The difference between 6 and 2.5.
That's correct. It's the difference between 6 and 2.5. That would be the the forced vital capacity. This value is the volume, right? It's the volume of gas that you can maximally exhale after a deep inhalation. Bless you. Does that make sense, guys? This is what is referred to as a volume time tracing, because I'm plotting volume against time. Duh. Okay.
So you don't really have to worry about that before you start flowing in.
Correct. The maneuver begins there and ends there. So it's 3.5 liters. Is the value. 3.5. That would be what is the forced vital capacity. Now the question begs itself, and we'll talk about this in a little while. Is that value normal? Is that value okay? I don't know. Who's it done on? Okay, it's going to vary based upon a couple of factors. If I take Jason and I take Susan, I have 2 different genders, 2 different heights, 2 different ages. I'm making the assumption here. Okay. Those 3 parameters are 3 of the things that will alter as those things change. Pulmonary function values will change. No. It does only in the sense that somebody who's 650 pounds who's morbidly obese, yeah, it's a factor, but as far as generating what their predicted is, no. And we'll talk more about that towards the end today. Okay. So this is, again, the most commonly performed test. This is one we'll do at the bedside, we'll do in a doctor's office, we'll do whatever. the American Thoracic Society has a position statement that any patient who's 50 years or older who smokes should have a pulmonary function done as a baseline. We talked about COPD prior, bronchitis and emphysema. Most patients who suffer from that don't get diagnosed until they have basically half of their capacity gone. So their lung is only 50% of what it possibly could be. That's about the time they present to the physician. Pretty late course when you think about it. Ought to be. So from that volume, from that force vital capacity tracing, we can derive a bunch of other measurements. And these are called the forced expired volume. Notice it's the volume. That's timed. And it's basically what is the volume that is exhaled from a maximal forced exhalation at a half a second, at 1 second, at 2 seconds, at 3 seconds, etc. The most common one we end up using is this one, what is known as the FEV1. In other words, what's the volume of air that you can forcefully exhale in 1 second? This is called your lung number. Just like a person with hypertension watches their blood pressure and monitors their blood pressure, just like a diabetic would monitor their blood sugar, or more commonly something called the hemoglobin A1C. Patients with lung disease, we track their FEV1. All of us are slowly deteriorating as far as our lung condition. Okay, our ability to have functional lung tissue goes away as time goes on. As we age, this value, the FEV1, will become smaller and smaller. Okay. If I smoke, that deterioration is much more rapid. Okay. Pick an age there, whatever. If I stop smoking, it goes back to the normal rate of decline, but you never get the lung volume back. That amount of functional lung tissue is gone. Other than a lung transplant, ain't much you can do about it. Okay? So, is it important for patients who have lung disease to stop smoking? Absolutely. Even patients with lung cancer, it's important that they stop smoking. But getting back to my FEV1, that's the value we're going to pay close attention to. Okay? The volume of gas that you can exhale in 1 second forcefully. Volume of gas you can exhale forcefully in 1 second. Said better. Okay, but we can look at other half seconds, 2 seconds, etc. But it's the FEV1 we typically look at. So when we measure this, we look at where that 1 second point is. So here's 1 second, starting here. Right, can everybody see that's 1 second? So I go over 1 second, and I come up until I'm at this point. And I see what the FEV1 is, what's the volume that we have there. I can then compare that FEV1 to the FVC. Be helpful if I wrote that a little bit better. We're going to call this the FEV1%. How much can I forcefully exhale in 1 second compared to how much I can forcefully exhale in total? Normally somewhere mid-80s, but the key part here is if it's below 70%, you'll have a disease present. If I have an obstructive disease, one of those sea babes, both the vital capacity and the FEV1% is reduced. If I have a restrictive disease, the FVC is reduced, but the FEV1% is normal. And we'll play around with this, because the goal is for me to give you some data and you tell me if it's an obstructive or a restrictive pattern that is present. Or it may even be a real rat bastard and give you a PFT. Not only do you have to figure out which is which, but which of the following diseases would have this kind of a pattern. I know you're all excited. Two other measurements that we still get from that same tracing. So here was my breathing tidal, come on you, and breathing tidal volume. Take a deep breath in, blow it out maximally. 2575 says this is a flow rate. What is the average flow during the middle of that maneuver? And this gives us a handle what the condition is of the medium to small size airways. Not your big airways, not your main stem lobar bronchi. We're talking more along the lines of the subsegmental and bronchioles. Okay. I don't care that you know the normal values. Okay. Would never ask you that. But what I would say is which test will tell us how well the medium to small airways are. We used to use this more so as an early index of somebody who had a propensity to perhaps have COPD later in life. So in other words, if a younger person had a reduced value here and they were a smoker, we could use that as kind of a, this is the position you're in. You may want to consider quitting smoking. 2575, middle part of the FVC maneuver, medium to small size airways. And this is, I used to have people calculate this out and nobody remembered it, so I just dropped it. Who am I kidding? But basically, if I have my vital capacity being this value here, what is 25% of that value? What's 75%? Find those 2 points on the curve, draw a line. Slope of that line is going to be a flow rate because it's volume per unit time. Blah, 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 blah. Nobody paid attention to me, so I stopped. 2575, medium to small. 200, 1200, which is another one. You'll see this depicted. Are large airways. So 2575 medium to small, 200, 1200 big. That's all I want you to know. Yeah.
There was a slide here right before that kind of compute the force export flow, so.
No, don't worry about it. In the last flow rate that we want to talk about, you'll see the abbreviation a couple different ways, but it's the peak expiratory flow rate or the peak flow. And this is the maximal flow that you can attain, and it occurs at the very beginning of the breath. If you think about it, if I have you take a deep breath in maximally and blast it out hard and fast, the fastest flow you're going to generate is the very beginning, because your lungs are full. They want to recoil back. They're going to blast it out and have the highest flow at that point. This is actually one of the ones that we have the patients monitor at home, because it's easy for them to end up doing it. A simple device called a peak flow meter, basically just a reusable, I don't know how else I want to describe it. It's a little monitor that doesn't have, it has some moving parts, obviously, but you can very easily be able to monitor your asthma at home, and we'll talk more about that when we talk about asthma management. The problem with peak flow is it's very effort dependent. The other ones I've been talking to up to this point in time are not effort dependent. Take a deep breath and blow it out hard. No, blow it out hard. You can't, if I'm looking at how much you can blow out in 1 second, it's hard to fake that. It's easy to fake this. So you really got to monitor the patient, make sure they're doing the maximal effort at that point in time. Peak flow. This is a different kind of tracing. Up to this point in time, I've been drawing a volume time. This is what is called the flow volume loop, where I'm monitoring flow rate against volume. And what is my peak flow? And here I got a PEF, peak expiratory flow rate. Peak flow. What is it? How much? 5 what? 5 liters per second. How many liters per minute is that? Oh boy. 5 liters per second times 60 seconds per minute, 300 liters per minute. Unfortunately, in the PF lab, we measure in liters per second. In the ER, you measure in liters per minute. So you need to go back and forth between the two. Do you think they'd make it easy on you? Nah. That would make my job too easy. Now notice we not only have the peak expiratory flow, we have the peak inspiratory flow, where this is an expiratory maneuver, this is an inspiratory maneuver. So take a deep breath in, blast it out hard and fast, push, squeeze, keep go. Now take a deep breath in. The shape of these curves will end up changing based upon whether or not there's disease or not. And this is kind of hard to visualize because it's upside down of what I've been talking about. I don't know why they did that, but you can see that the size of the FEV, the vital capacity, changes as lung disease changes. What also changes is that slope of the line, and we'll talk more about that because that's the important thing. All right, a couple other tests just to mention. One is what is called the maximum voluntary ventilation, or MVV. It's a test that only lasts 12 to 15 seconds because, as I describe it, you'll know why. You basically want the patient to take as deep and as fast a breath as they can. Yeah. Try getting an 82-year-old to do that. It becomes very difficult. But it's a good index of how much capacity they would have if stressed. Okay. If you're being chased by that, lion down the street, how much could you maximally do? That's kind of the idea behind it. And it only lasts, like I said, 12 to 15 seconds because we pass out. And I have had patients pass out doing it because they get so lightheaded. Yeah. Okay. Breathe normally. Now breathe fast. Yeah. And then they flatline. That's right. We talked about the flow volume loop, where I basically have the patient take a deep breath in and maximally blast it out, and then take a inspiratory maneuver. Okay. What we're going to see, though, is that on a patient who has obstructive lung disease, the middle portion of this expiratory curve is going to be scooped out. So as I have this patient exhale, this middle part, the 25 to 75, that small to medium-sized airways now have a reduction in flow through that area. So they're going to have a curve that actually looks like this. Like somebody just took a big scoop right out of there. In fact, we call it a scooped out flow volume loop. And it's classic for patients with obstructive lung disease. Okay. If I do identify somebody who has an obstructive lung pattern, I want to know if it's reversible at all. Because sometimes that flow deterioration can be improved with medication. So we'll do a pre and post bronchodilator, where we'll go ahead, do our measurement, and then reevaluate it to see if there's an improvement in the FEV1. We're going to define a reversible lung problem as having both a 12% improvement and a 200 milliliter improvement. So I look at my post minus my pre divided by my pre. Put another way, my new minus my old divided by my old. Just say no. I do that measurement or do that calculation. If it's greater than a 12% change and a 200 milliliter change, I can see that that patient has a response to a bronchodilator. If it's not, they don't. And sometimes COPD patients will have some improvement, and it makes sense then to begin them on a regimen of having a bronchodilator as part of their daily medication. Pre and post. Okay. Let me introduce this concept, and we'll come back to it. First of all, remember that the smaller airways do not have cartilaginous support, right? Once you get down to the bronchioles, now you start losing cartilage. So those airways are going to have a tendency to be the ones that are going to collapse. That's small to medium-sized airways. That's 25 to 75%. FEF, 25 to 75. During a forced exhalation, any collapse is going to be exaggerated. It's going to be, you're going to see it much more pronounced during a forced maneuver than you will during a non-forced. And the reason being is that the pressure outside of the airway exceeds the pressure inside the airway. When I do a forced exhalation, I'm pushing so hard that the pressure outside is greater than the pressure inside and the airway collapse. The point at which the pressure inside and the pressure outside are the same, I have a unique name for it. It's called the equal pressure point. What a novel idea. Just prior to that airway collapsing. If I'm looking at the tracheobronchial tree, the further up that equal pressure point is, the more problematic it is because you're trapping more gas behind it. In other words, I'm not getting as much air out. This is why that forced vital capacity and the slow vital capacity would be different in patients with obstructive, because their airways collapse. They're much more prone to collapse, especially the smaller and medium-sized airways. This is what it's kind of showing, that we end up having at a maximal forced exhalation. There's a point at which the pressure outside is equal to the pressure inside. That's my equal pressure point. Anything distal to that's going to be a collapsed airway. A little bit of a difficult concept to grasp first time through, so I'll come back and visit it another day. But that's the reason why we have a difference between slow and forced vital capacities. Okay. Now, we don't really call them normal values. We call them predicted values, because it's basically just done based upon your height, your gender, and your age. How big of lungs do you have? What is your ability to not only get a volume in, but to exhale it in a forceful manner? The way they derive these is they looked at a group of people. They measured, quote-unquote, normal people, and they found out what their measured values were. And I'm talking tens of thousands of people. And then from that they said, okay, here's what it was for a 26-year-old female who's 5'2". Here's what it is for a male who's 62 and 6'5", blah, blah, blah. Okay? And they put them all in a big database, and they did what they call a linear regression, which you guys don't care about. But basically, they're able to predict what value you would have based upon your height, gender, and age. Notice the important things. Weight is not factored in. Is weight important? Absolutely, as you were saying. If I got a 600-pound person, yeah, that's a heck of a lot of fat tissue that's sitting on the thoracic cage. It's going to be an impairment to ventilation, but it's not determining my predicted values. Height, gender, age. Now, the real question is ethnicity. And there is a difference with some ethnic groups. African Americans typically have longer legs. I'm generalizing here, please. Typically have longer legs, so their height is not indicative of their thoracic length. Asian, Pacific Rim are shorter legs, but they typically don't have necessarily their height is not indicative of their thoracic cage size. Does that make sense? So for some ethnic groups, we actually have created separate tables based upon ethnicity. Or we'll take usually we'll adjust the predicted value up or down based upon their ethnicity. We then compare their actual value that we measured to their predicted. And determine a percent predicted. So that's actual divided by predicted times 100%. It's a very difficult calculation to make. I'm kidding. And one of the things that I would expect you to be able to do is to do that calculation. It's not like it's a tough bit to do. We're going to consider quote-unquote normal 80 to 120% of their predicted value. So long as somebody's above 80% of their predicted, we're doing good. The exception to that is that FEV1 to FVC ratio that has a cutoff of 70%.
That formula will equal to what? Their predicted?
Their percent predicted. So if my actual was 4.0, my predicted was 5.0, 4 divided by 5, %. Okay? This chart is blown up so it's bigger. You can read it in the back of the section, or should be. And it's really a two questions that you have to ask yourself looking at a pulmonary function data. And we'll go ahead and practice these in a sec. First of all, the first question, the first step, is you look at the FEV1 percent. So this is, if you remember, is this. What's my FEV1? What's my FVC? Divide the FEV1 by the FVC, multiply times 100%. If it's greater than 70%, let me rephrase that. If it's less than 70%, I have an obstructive disease. End of the investigation. Check, please. I'm out of here. Okay? In all obstructive diseases, with the exception of asthma, because that's asthma is episodic. When they're not having an asthma attack, their pulmonary functions are normal. It's only when they have the attack that you end up having an obstructive element present. So if it's less than 70%, I'm classifying that as an obstructive defect, and we're done. If it's not less than 70%, 82%, I then look at the FVC and see if it's less than 80%. If it's less than 80%, I have a restrictive disease process. If it's not less than 80%, I have a normal lung. Okay. I measured it.
Oh, okay, so it's just that value.
It's that value there. Yep. Okay. Let me show you, and this is on my website. You can download it if you want. But this is a random generator.